Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran, will present an article published in the July issue of IJA. It is on intraoperative goal-directed fluid therapy in adult patients undergoing craniotomies under general anesthesia. It is a systematic review and meta-analysis with trial sequential analysis. Fluid therapy during intraoperative period is vital. Significant hemodynamic variations may occur during surgery due to blood loss and fluid shifts, where hypovolemia can decrease the perfusion of the end organs, whereas hypervolemia can lead to congestion and compromise the function of the organs. In neurosurgical patients, hypovolemia can cause cerebral ischemia, whereas hypervolemia can lead to cerebral edema. Therefore, conventional intraoperative fluid therapy, which is based on clinical parameters, hemodynamic monitorings like CVP and holiday cigar formula, fail to detect the dynamic circulatory changes. Goal-directed fluid therapy means the titration of fluids and inotropes according to the predefined hemodynamic goals to maintain adequate organ and tissue perfusion. In neurosurgical cases, fluid and electrolyte imbalance is common, and therefore maintaining tight fluid balance is crucial. Therefore, this systematic review and meta-analysis was planned to compare intraoperative goal-directed fluid therapy and the conventional fluid therapy in neurosurgical patients undergoing craniotomy for intracranial pathology. The primary objective of this trial was to determine the proportion of patients with good neurological outcome, whereas the secondary objective was total fluids administered, blood loss, post-operative complications, ICU, and hospital length of stay. The research question of this meta-analysis was, what is the effect, good or worse, of intraoperative goal-directed fluid therapy in adult patients undergoing craniotomy under general anesthesia on the neurological outcomes? The meta-analysis is reported as per the PRISMA guidelines, and the trial is registered with Prospero. It is a systematic review and meta-analysis which included all RCTs conducted in adult humans undergoing craniotomy for intracranial pathologies, comparing goal-directed fluid therapy with liberal or traditional or a standard fluid management. No restriction on type of modality used for goal-directed fluid therapy was there, which included stroke volume variation, pulse pressure variation, left ventricular outflow tract velocity time integral, cardiac index, stroke volume, cardiac output, pleth variability index, global end diastolic volume, and oxygen delivery index. The studies excluded were those on animal experiments, any retrospective studies, and incomplete data for review and quantitative analysis, like the presence of abstracts only, protocols only, review articles, and case report and series, where elective neurosurgical patients cannot be isolated from conditions like VP shunts or minor procedures like burr holes or studies where outcomes were not reported. The search strategy included PubMed, Embase, Scopus, ProQuest, EBSCO host, and Cochrane till 16th October 2023. The keywords were neurosurgery, craniotomy, supratentorial, posterior fossa, infratentorial, intracranial aneurysms, traumatic brain injury, head injury, goal-directed, goal-oriented, goal-target fluid therapy, restricted fluid therapy, neurological outcome, Glasgow outcome score, mortality, post-op complications, cerebral edema, vasospasm, modified Rankin scale, kidney injury, hospital duration, and total fluid. The risk of bias was assessed using ROB2 tool from Cochrane collaboration. The pooled estimates of the outcomes along with 95% confidence intervals were measured in terms of relative risk and mean differences. A post-hoc trial sequential analysis was done for 7 critical outcomes. The primary outcome was neurological outcomes in terms of Glasgow outcome score and the modified Rankin scale, whereas the secondary outcomes included post-operative complications which included both the medical as well as the surgical complications, that is, renal failure, pulmonary or cardiac complications, electrolyte abnormalities requiring interventions, cerebral edema, intracranial hematoma, de-exploration surgery, vasospasm, or use of radiological interventions. Another secondary outcomes were total intraoperative fluid requirements, the intraoperative blood loss, duration of hospital stay or ICU stay, as well as mortality. A total of 10 RCTs were included in the meta-analysis with 608 total participants. The experimental group, which is the goal-directed fluid therapy group, included 309 patients with a mean age of 41 to 61 years, whereas the control group included 299 patients with a mean age of 39 to 58.4 years. 5 studies were on intracranial tumors, 1 on intracranial aneurysm, and 4 included all the craniotomies, including abscess, tumor, or aneurysms. The risk of bias assessment is shown where there was uncertain risk of bias due to randomization in 4 studies, uncertain risk of bias due to deviation from intended intervention in 2 studies, uncertain risk of bias in the D4 category, that is outcome measurement in 1 study. Out of these 2 studies were at high risk of bias. Now, these are the results for the primary outcome, that is the neurological outcome seen using Glasgow Outcome Score or Modified Rankin Scale. 2 studies were included for the estimation of the neurological outcomes, and there was no difference either in the goal-directed fluid therapy or the conventional group therapy when compared for neurological outcomes. This is for overall complications. You can see overall complications were lower with the goal-directed fluid therapy. Now coming to the pulmonary complications, again, the pulmonary complications were lower in patients with goal-directed fluid therapy when compared to the conventional fluid therapy. The renal complications were similar in patients with goal-directed versus the conventional fluid therapy. Total amount of fluids used was also comparable between both the groups. As you can see, blood loss was also comparable between both the goal-directed fluid therapy and the conventional fluid therapy group. Coming to the duration of ICU stay, it was significantly lower in patients who received goal-directed fluid therapy in the intraoperative period versus those who received the conventional fluid therapy. And the total duration of hospital stay was also favoring the goal-directed fluid therapy. As you can see, the parameters of overall complications, pulmonary complications, hospital stay, and ICU stay have a high level of certainty of evidence as compared to neurological outcomes, the renal complications, the total fluids. Trial sequential analysis revealed that the required sample size was met for the blood loss, hospital stay, and ICU stay. However, much greater sample size is needed for pulmonary and renal complications. The software could not compute this for neurological outcomes and overall complications due to small number of studies. Now, the result of these studies revealed no significant effect of goal-directed fluid therapy on the neurological outcomes. Post-operative complications, hospital and ICU length of stay was significantly less in the goal-directed fluid therapy, but the other outcomes were comparable. Anaesthesia et al. Compared goal-directed fluid therapy with standard therapy throughout the hospital stay in patients with aneurysmal SAH, where goal-directed fluid therapy group had significantly lesser incidence of delayed ischemia and better neurological outcomes at 3 months post-discharge. Another study showed similar results in post-clipping and post-coiling poor grade patients. Therefore, goal-directed fluid therapy should be continued till the patient needs systemic fluid administration in future studies, and this may enable to appreciate its effect on the neurological outcomes in the patients. Similar observations are noted in meta-analysis done on post-operative complications using goal-directed fluid therapy in non-neurosurgical patients also, which includes major GI surgeries and non-cardiac surgeries. Intraoperative goal-directed fluid therapy reduces the post-operative complications because of better maintenance of the systolic blood pressure as well as optimal volume without over or under hydration. Total amount of IV fluids was similar in both the groups. This may be because of high heterogeneity was observed for this outcome, and it is suggested that larger multicentric trials with uniform targets and algorithms should be included to reach a firm conclusion on the amount of intraoperative fluid used. Intraoperative blood loss was also comparable, as in neurosurgical procedures, the blood loss depends primarily on the vascularity, size, and location of the lesions, the technical difficulties, and surgical expertise. The reduction in post-op complications explain significantly lesser duration of ICU stay as well as hospital stay in the goal-directed fluid therapy group. The limitations of this meta-analysis is there are small number of high-quality studies. Composition of fluids governing the osmolarity and solute content will also affect the outcomes. But the studies have used different type of fluids in this meta-analysis. There is heterogeneity in the type of fluid used, the fluid protocol used for the goal-directed fluid therapy, the technique of goal-directed fluid therapy used, what was the parameter used, and the outcome studied. The certainty of evidence is of low grade for the primary outcome as per this meta-analysis. Therefore, concluding this meta-analysis, the pooled data of this meta-analysis showed that neurological outcome was not affected by intraoperative goal-directed fluid therapy. Still, it was associated with reduced post-operative complications and ICU and hospital stay, thus reducing the overall cost. Thank you so much.